happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. Yes, a quick note, guys. I'm waiting for that. If I'm audible and visible, so that we can start with the discussion. Okay, that's great. And I hope that all the FMG students here who appeared for the exam, you did well in the exam. The overall review has been that the part 1, paper 1 was easy, straightforward, while paper 2 was a bit weird without any ECGs and ABGs, right? It was more concentrated on oncology, the cancer staging and treatment. So in this session particularly, we are going to discuss the radiology questions. I hope I'm audible. Okay. So in this session, we are going to discuss the radiologic questions, and which are again not very difficult ones. The ones that are, the common questions and the questions that can be solved by the cheat codes, as I call them, by the smart way of approaching the MCQs. Right. So let us start with the discussion, and let me also tell you that these questions are based on recall, and they might not be the exact questions that appeared in the exam, but the idea is to give you an idea about what topics, what questions were asked, especially for the NEET PG students, so that you get an idea that what questions were asked in recent FMG exam, the same board conducting the exam. So we need to cover those topics for our upcoming NEET PG exam as well, right? The final questions, after a lot of the discussions and various recalls, the final questions will be uploaded on the PrepLadder app, and they would be accessible there. All right. So starting with the discussion of the questions here. First question here, identify the marked structure in the given chest X-ray. Somehow we have always seen that in the FMG exam, one at least radio anatomy question is asked. Chest X-ray ho, pelvis X-ray ho, musculoskeletal X-ray ho. That has been asked very, very frequently. So radiology and anatomy integrated is a very important topic that we should master it, right? So let's have a look at this radiograph first, and how do we calculate the ribs? Okay, how do we calculate the ribs here? So what do we have here is, this is the uppermost one. This is the first rib that we have. Okay, that's the first rib that we have. Uske niche, this is the second rib, right? Now this is the third rib, and this one is the fourth rib. So remember that we have to count the ribs very, very carefully. So सबसे ऊपर ये जो broad और ऐसे छोटा वाला rib दिख रहा है, that's the first. Then we have second, then we have third, and then we have the fourth one, right? So this is the fourth rib. So first of all, what do we know from here is that this is the fourth rib. So automatically we rule out the options. This is not the third rib. This is not the third rib. So answer is either option C or option D. Remember, in MCQ exams, ruling out the options is very, very important. Okay, that is very, very important. Now, I'm not really sure where the arrow was marked, because here in this image it is somewhere between like the posterior and the anterior end. Now how do you identify the posterior and the anterior end? So the part of the rib which is more flat, okay, which will articulate with the vertebra, that is the posterior end. This part here, which is basically not clearly visible because it is oriented obliquely. The posterior part of the rib is flat. The chest X-ray, the beam goes horizontal tangential. So the posterior ribs are seen very clearly. Okay, right, the flat horizontal ones, and these are oblique ones. We know that the anterior end of the ribs, they articulate with the costal cartilages. So that is why the medial most part of the anterior rib, we don't see them ossified, because they are articulating with the costal cartilages here, right? Cartilage will not be seen. Cartilage will not be seen in the chest X-ray, right? Cartilage will not be seen in the chest X-ray. So this one here is the fourth rib, and this is the anterior part of the rib. This is the posterior part of the rib. So if the arrow was here, which is like actually the junction of the posterior and the anterior, if the actual arrow was also here, then you can mark it as the posterior end. अगर यहाँ पे होता तो very easy रहता, this is posterior. अगर यहाँ पे होता तो easy रहता, ये anterior है. This is ideally the junction. So this is fourth rib posterior end is what I would call it, particularly the junction of the posterior and anterior end. And I hope the concept is clear here, right? How will you identify what is the anterior and what is the posterior end? So anterior part is the oblique one and posterior part is the horizontal one. Okay, that is the horizontal one. Is this clear with everyone? Right? Going on to the next question. Right, though not radiology questions, but let us discuss this quickly with some easy tricks. And this was posted on a recent social media handles as well with the mnemonics. Identify the pelvis type. So in the pelvis type, let me quickly tell you the tricks on how to remember the pelvis types. So what do we have? Gynecoid, remember G for G. Gynecoid is goal. That means it is circular. AP transverse diameter are equal. Anthropoid is AP. So AP diameter is more than the transverse diameter. Anthropoid is like this. Platypoid, which has T prominent in its the pronunciation. Platypoid. Platy is flat, which is transverse. T is transverse diameter more than the AP diameter. And we have android. Android is like do, isko ulta pado do, and di is dil. It's like do dil mil rahe hain. So remember that android is like do dil mil rahe hain, which is heart shape. Okay, which is heart shape. So what do we have here is the goal pelvis. Basically, this would be gynecoid pelvis. Again, as I said, the idea is to help you remember. If at all this question appears in the upcoming exams, you should know how to solve those questions. So remember that round, goal is gynecoid, anthropoid, AP more than transverse, platypoid is transverse more than AP, and android is do dil mil rahe hain, that is like heart shape. Okay, that is heart shape. Going on to the next question here. Now, whenever you have some lengthy questions like this, always use the trick of reading the last line first. Which of the following investigations can be useful in this condition? So I know that it is somewhere asking me about the investigation. So now I need to know that what is the diagnosis that has been put forth. So the diagnosis that has been put forth, read the second last line then. It is given that it is hyperparathyroidism. Already it is given that you suspect a case of hyperparathyroidism. So you need not read the entire question. This saves a lot of time. So hyperparathyroidism, ideally USG neck can also help in localizing the parathyroid. Parathyroid adenoma appears very hypoechoic with high vascularity. So on USG neck also we can localize the adenoma, which appears very hypoechoic with increased vascularity. But it will not be a very specific diagnosis. More specific that we have is the Cysta-Mealy scan. Okay, that is the Cysta-Mealy scan. Let me just see, guys, if I can work on. Is the volume any better now? I'm just trying to work on the volume. Let me just check that. Okay. So Cysta-Mealy scan. Okay, Cysta-Mealy scan is the one which is the Cysta-Mealy scan is the one which is the radionuclide scan, the scintigraphy that we do for parathyroid. Hyperparathyroidism, it could be parathyroid adenoma, it could be parathyroid hyperplasia. Cysta-Mealy scan, Cysta-Mealy is taken up by parathyroid and also by thyroid, right? So for parathyroid, this is actually a repeat question. This has been asked in the previous exam as well. So remember, Cysta-Mealy scan is done for hyperparathyroidism. It gets localized to the parathyroid. We see the increased uptake. And hyperparathyroidism, the history also, if you look at the history, stones, right? What is the complaints in hyperparathyroidism? It is stones, it is bones, and it is moans, right? So there are kidney stones, then there is bone pain. Parathyroid causes bone resorption, there is bone pain, and moans, right? There is abdominal pain as well, and there are psychiatric complaints as well. Okay. So and also remember, next time if you are asked the question ki parathyroid क्या करता है calcium और phosphorus, parathyroid hormone, right? Remember that parathyroid hormone, it increases the calcium and it decreases the phosphorus levels. Primary hyperparathyroidism. So you can remember this as parathyroid. PTH has OPT, that is opposite actions on calcium and phosphorus. Increases calcium, decreases phosphate levels in the primary one. Okay. So this was okay, this was about hyperparathyroidism. Remember the Cysta-MeB scan, it's a favorite with the examiners in the nuclear scans. Next question that we have here. Again, if it seems like a lengthy question, I would first like to read the last line. Which among the following is the best treatment for the following condition? Now, I know that the question is asking for the treatment, and I would first like to make a diagnosis here. Now, this is again a repeat question, sort of repeat image. Last time the question was asked whether the coin is in the trachea, it's in the esophagus. This time it has been asked about the treatment, it's actually the same, right? So, how do you identify whether the coin is in esophagus or the coin is in trachea? Now, if the coin goes into the esophagus, let us imagine that this is the coin. Okay, so this is like the circular coin. If the coin is going into the esophagus, esophagus is a muscular structure. It expands and it will allow the coin to go straight like this. So when you take a AP view, frontal radiograph, you would see the coin like a circle in the frontal radiograph. Same coin if you see from the side, this is the side of the coin. I will just see the slit. The coin will appear like a slit. It will not be a circular coin. So it is circular in the AP view and it is slit like in the lateral view. Opposite is with trachea. Okay, opposite is with trachea. Trachea के साथ क्या होता है? The trachea does not expand. So the coin has to adjust to the narrow space of trachea. So the coin rotates and the coin goes like this. So if you see from the AP view, the coin appears like a slit. On the lateral view from the side, the coin is circular. So what did we see here? What did we see here is in esophagus versus in trachea. Esophagus AP view, trachea and lateral view. In the esophagus, AP view is circular, lateral view is slit-like. Trachea is opposite, AP view is slit-like, lateral view is circular. Okay. So, how can you remember this? What is the trick to remember? अगर trick से याद करना है इसको, so you can remember this as esophagus is circular in the AP view. Trachea is T. Okay, remember T is like this slit, the vertical line, and that is the trachea. So in the AP view, esophagus circular, trachea is the slit like in the AP view. Okay, so now since the coin is in the esophagus here, why? Because I can see that on the AP radiograph, this is the frontal radiograph that we are seeing. Lateral radiograph will have the overlapping of the lungs. So this is the coin in the esophagus. So what we need to do is esophagoscopy, endoscopic removal of the coin. Why? Because the child is symptomatic. So wait and watch. The child is having difficulty in speaking and breathing. That means the child is symptomatic. So in that case, we need to do esophagoscopy. Is this clear with everyone? Okay, there is some voice issue. I'm sorry for that. Next time we will definitely take care of that. अब ये वाले session में just bear with this, है ना? I hope at least it is audible. It's not like I am mute and I'm not audible. Okay, so that is the post-exam doom doom and the DJ speaker जैसा vibration that you are feeling, है ना? ये post-exam वाला है. Never mind. Let's go to the next question. Please ignore this image. And the question is, what is the gold standard investigation for fistula in NO? What is the gold standard investigation for fistula in NO? Yes, absolutely right. It is MRI. Okay, it is MRI that we do for fistula in NO. You know, MRI. So we need to do MRI for fistula in NO, the perineal region. We do the MRI. We know that in MRI we use the coils. On what part of the body we are imaging, we use the coils. So for the fistula in NO, we can use the body coil, or we can use the endo-anal coil as well. We can put the coil endo-anal. This is of course discomforting, and body coil is generally used. So in MRI, for general principle, remember that for perineal pathologies, MRI is the investigation of choice, right? And it helps you identify the tracks very definitely. You know how is the track, where it is going, that can be identified very well on MRI. Okay, that can be identified on MRI. ठीक है? Clear with everyone? Okay. Sinogram was also there in the option, fistulogram or sinogram as it is asked. So in that case, even that would be, yeah. So sinogram, again, it is not going to tell you the exact pathway. MRI will give you the definite, you can visualize, you can see the rest of the structures also. So MRI is now done more than the sinogram. Okay? Okay. Going on to the next question. Identify the disease. Again, I'm not reading the entire question. I'm just telling you the tricks here on how to solve the questions fast. The question says chronic knee pain hai, x-ray hai, and identify the disease. Now, this is a very straightforward image that we have here. And this we see that the lesion is continuous with the bone cortex. It is an outgrowth from the bone. So, this is exostosis. Exo matlab out, ostosis matlab the bone growing out. So exostosis, that is osteochondroma, is the other name for exostosis. It can be pedunculated like this, or it can be sessile as well. So that is osteochondroma. Giant cell tumor. Okay, giant cell tumor. Giant cell tumor involves the epiphysis. And remember the points for giant cell tumor. Giant cell tumor, remember, like egg. It involves the epiphysis. Giant cell tumor involves the epiphysis. Everyone here, regarding the volume, I've tried my best to increase the volume. इससे ज़्यादा ये बढ़ नहीं रहा है. That's the reason that even I am not able to help it out here. Give me a minute if I can see if I can increase the volume. ठीक है, अभी मुझे बताओ कि वॉल्यूम बेटर है. Is the volume any better now? Perfect. Okay, that's great. Amazing. So thoda, it's very important to be technically sound and technically good. I've realized, especially with the live sessions. Chalo, great. So giant cell tumor, the points I was telling you is giant. Remember, egg. Epiphysis is giant cell tumor. Remember, giant cell tumor occurs in a giant person. Giant person, matlab it occurs in an adult after the skeletal maturity. Okay, it occurs after the skeletal maturity. And Next that we have is, remember that giant cell tumor, giant involves the joint. The only tumor which is known to go till the joint surface, the articular surface, is the giant cell tumor. So egg, epiphysis, giant person, and involves the joint. Osteosarcoma, remember osteosarcoma, S for sunray or sunburst pattern of periosteal reaction is what we would see with osteosarcoma. Ewing's is in a child and it has onion peel periosteal reaction. Okay, there is a onion peel periosteal reaction. Okay? Is this clear with everyone? So this is osteochondroma. When we have multiple osteochondromas, it is called as diaphyseal achalasia. Okay, it is called as diaphyseal achalasia or hereditary multiple exostosis. Okay, and classically the history in osteochondroma will be कि clinically the tumor appears larger, but when you take a X-ray, it is small. It is smaller on X-ray. Why is that so? Because osteochondroma, osteobone, chondroma is the cartilage cap. The cartilage cannot be visualized on X-ray, right? So it will be large clinically, but X-ray pe utna large nahi hoga. And what investigation do we do to look for this cartilage cap? What investigation? We do MRI. Okay, we do MRI because cartilage is best seen on MRI. The increase in the cartilage thickness more than 2 centimeters tells us that osteochondroma is becoming malignant. Okay, it is becoming malignant, right? So that was about this question. And going on to the next one, ground glass appearance on lung is seen in which of the following? Ground glass appearance on the lung. If these are the options given, let's try ruling out the options. Okay, let us try ruling out the options. So what do we have is pleural effusion is outside the lung. When I say it is ground glass appearance, okay, when I say it is ground glass appearance, so ground glass means that the alveoli are filled with something that gives the ground glass opacity. So first of all, it means that it is a parenchymal pathology. Okay, it's a parenchymal pathology. So automatically pleural effusion and pneumothorax are out. Okay, they are out. And then we have asbestosis and silicosis. Ideally, if these were the options, I'm not sure what were the options. Both of them can show the ground glass appearance. Asbestosis also leads to interstitial lung disease, right? Even that can show the ground glass appearance. Okay, that can show the ground glass appearance. So ground glass appearance is also seen in the initial stages of the interstitial lung disease. Okay, the initial stages of interstitial lung disease. So the idea here is to tell you that ground glass is suggestive of parenchymal pathology. So you rule out the options of pleural effusion and pneumothorax. Okay, pleural effusion and pneumothorax options is what you rule out. Silicosis is something which mimics tuberculosis. This is a previous year question. Which occupational lung disease mimics tuberculosis? It is silicosis. Okay, it is silicosis. Okay, going on to the next one. Identify the disease again, and the image is given and the options are given. Again, without reading the entire question, we can try to answer this. So where are the stones? Where are the calcifications? This is where we see the white calcifications, the white stones. Look at the option. Calyx, ये kidney नहीं है. We are already at the level of the pelvis, right? So that means a kidney तो नहीं है. So this is not stone in the calyx. This is not stone in the kidney pelvis. Okay, so what do we have is ureteric stone और bladder stone. We are left with those options क्योंकि ureter आएगा pelvis में और pelvis में होगा bladder. Bladder stone ऐसे इतने multiple और line में नहीं होंगे. Here we are seeing the stones that we are seeing here. Okay, the calcifications, the stones that we are seeing here, they are in a line and they are following the ureteric course. Okay, they are following the ureteric course. So this is ureteric calculi. Okay, this is basically ureteric calculi. This is the question that we have received. If there was any other treatment, what was the options given for treatment? We need to look into that. and the surgery faculty can take care of that. Okay, so my idea is to tell you that this is how you identify the ureteric calculi. कि ट्यूब में है तो ये ऐसे vertical oval होंगे, follows the ureteric course. Kidney calculi will be ऊपर, okay, they will not be here. ठीक है? All right, and yes, you are also given the history of this pain going from the loin to the groin. That suggests that it's a ureteric stone. That is ureteric colic, loin to groin pain. Okay, loin to groin pain is what we have. All right, going on to the next one. This is the image, and again the question is identify the condition. This is actually IVP that has been performed. And what do we see here? What do we see here? Look at the kidneys ka orientation. They are coming medially and it seems like a horseshoe kidney. Okay, this is the horseshoe kidney. So, horseshoe kidney is basically giving this joining hands appearance, one kidney fusing with other, the joining hands or the handshake appearance, or it is also called as flower vase appearance, or the handshake or the joining hands appearance. Okay? So these kidneys are oriented medially. That is what we are seeing. Normal kidney, it should be here. Okay, the two kidneys should be separate. So this is it was CT, it was not X-ray. Okay, CT scan image was given. So this is again a previously asked question. Even on the CT scan image, what you would see is, if this is the vertebra, you would see the horseshoe kidney like this. Okay, vertebra ke aage, you would see the two kidneys which are fusing like this, basically a U shape. Okay, that's a U shape that we see. And for your upcoming exams, remember the association of horseshoe kidney is associated with Turner's syndrome. Okay, it is associated with Turner's syndrome. What prevents the ascent of the kidney is which artery? The inferior mesenteric artery. Absolutely right, Apple Z. So that is the inferior mesenteric artery. So CT scan mein basically you would see the U shape that we would be having. Okay? How to differentiate whether it is IVP or X-ray calcification anamica? You would be seeing the image and you would be able to see, are you seeing in this image there is a ureter also? Particularly anamika, if I am talking about this image, what are we seeing? कि मुझे यहाँ पे ureteric भी opacified दिख रहा है, right? Both the kidneys are opacified. So this is IVP. This is not a X-ray. X-ray में दोनों kidney symmetrical opacification and the ureteric opacification ऐसा नहीं दिखेगा. ठीक है? So this is the IVP image. The flower vase appearance, handshake appearance. That is the horseshoe kidney. Okay, that's a horseshoe kidney. All right. So those were the questions that we had received from radiology. I would say that they were not very difficult. By using the smart cheat codes, you could get the answers right. Remember, ruling out the options is something which we need to learn to score better in the MCQ exams. And let me also tell you about the Elite Pack that we are launching on PrepLadder, which has the updated new video lectures for all 19 subjects in both English and Hinglish. And we have the new question bank, which is next based with 70% of the clinical questions. You would also get the digital notes with the video lectures. There are treasures, which are high yield tables and the list for your easy revision. Rapid revision, snapshot videos including all the images. We have the mock test also that will be on the latest exam pattern on the previous year MCQs. They are available both in the theoretical format, the test format, and also as video discussions. And we are starting the pre-booking for the Elite plan, which is going to help for your next preparation. It is starting on January 21, that is tomorrow. And the early bird offer, it's like half the price at around 25K for 9 months, plus you get 60 days, that is 2 months extra. It's like 11 months. So everything is included and you have the early bird offer. So make sure you make the best of it. Any other questions here? All right. So EDH ka bhi question tha. We expect one of those in the exams. I'm surprised that there was no pneumothorax or pneumoperitoneum. So adding on to the list, we have EDH, which is idly shape, which is a biconvex shape due to rupture of middle meningeal artery limited by sutures, and we see the lucid interval. Okay, lucid interval, remember lucid is ED. Lucid interval is seen with EDH, right? So we will add that as well. Okay, any other questions? If you remember, please do let us know. You can stay connected with me on the Telegram group as well. And we will come up with the final recall. This is just a preliminary recall that we have just received post-exam to give you the first-hand idea of what topics, what questions were asked in radiology. Okay? So, thank you so much, everyone. And I hope this gives you an idea, and this tells you, especially for the NEET PG aspirants, that same topics are repeated in a different manner, right? We have seen so many questions, images are repeat. The horseshoe kidney is repeat. The coin in esophagus is a repeat one, right? Many of them are repeat, and the rest are basically the direct easy questions. Okay? So thank you so much, everyone, for joining in, and I hope you've got to learn out of this session. Let's stay connected and let's ace the exams together. Thank you, goodbye, take care, and keep studying, keep revising, and keep winning.